Hi and welcome back to another video of Medic Notes. This video is on respiratory distress syndrome. For introduction, respiratory distress syndrome is a condition that primarily affects premature infants. It happens when their lungs haven't fully developed, specifically the alveoli, which are responsible for gas exchange. The lack of surfactant, a substance that helps keep the alveoli open, makes breathing difficult for these tiny lungs. For lung development, the lining of the alveolus consists of 90% type 1 cells and 10% type 2 cells. After 20 weeks of gestation, the type 2 cells contain vacuolated, osmophilic, lamellar inclusion bodies, which are packages of surface active material. This lipoprotein surfactant is 90% lipid, and is composed predominantly of saturated phosphatidylcholine, lecithin. But also contains phosphatidyl-glycerol, other phospholipids, and neutral lipids. The surfactant proteins, SPA, SPB, SPC, and sulfur monophosphide D, are packaged into the lamellar body, and contribute to surface active properties and recycling of surfactant. Surfactant prevents atelectasis by reducing surface tension at low lung volumes, when it is concentrated at end expiration, as the alveolar radius decreases. Surfactant contributes to lung recoil by increasing surface tension at larger lung volumes, when it is diluted during inspiration, as the alveolar radius increases. Without surfactant, surface tension forces are not reduced, and atelectasis develops during end expiration as the alveolus collapses. The timing of surfactant production in quantities sufficient to prevent atelectasis depends on an increase in fetal cortisol levels that begins between 32 and 34 weeks of gestation. By 34 to 36 weeks, sufficient surface active material is produced by the type 2 cells in the lung, is secreted into the alveolar lumen, and is excreted into the amniotic fluid. The concentration of lecithin in amniotic fluid indicates fetal pulmonary maturity. Because the amount of lecithin is difficult to quantify, the ratio of lecithin to sphingomyelin, LS ratio, is determined. An LS ratio of 2 to 1 usually indicates pulmonary maturity. The presence of minor phospholipids, such as phosphatidyl-glycerol, also is indicative of fetal lung maturity, and may be useful in situations in which the LS ratio is borderline, or possibly affected by maternal diabetes, which reduces lung maturity. The absence of phosphatidyl-glycerol suggests that surfactant might not be mature. For its clinical manifestations, a deficiency of pulmonary surfactant, most often due to prematurity, results in atelectasis, decreased functional residual capacity, arterial hypoxemia, and respiratory distress. Surfactant synthesis may also be reduced as a result of hypovolemia, hypothermia, acidosis, hypoxemia, and rare genetic disorders of surfactant synthesis. These factors also produce pulmonary artery vasospasm, which may contribute to IRDS in larger premature infants, who have developed sufficient pulmonary arterial smooth muscle to produce vasoconstriction. Surfactant deficiency-induced atelectasis causes alveoli to be perfused but not ventilated, which results in a pulmonary shunt and hypoxemia. As atelectasis increases, the lungs become increasingly difficult to expand, and lung compliance decreases. Because the chest wall of the premature infant is very compliant, the infant attempts to overcome decreased lung compliance with increasing inspiratory pressures, resulting in retractions of the chest wall. The sequence of decreased lung compliance and chest wall retractions leads to poor air exchange, an increased physiological dead space, alveolar hypoventilation, and hypercapnia. A cycle of hypoxia, hypercapnia, and acidosis acts on type 2 cells to reduce surfactant synthesis. And in some infants, on the pulmonary arterioles to produce pulmonary hypertension. Infants at greatest risk for IRDS are premature and have an immature LS ratio. The incidence of IRDS increases with decreasing gestational age. IRDS develops in 30 to 60% of infants between 28 and 32 weeks of gestation. Other risk factors include delivery of a previous preterm infant with IRDS, maternal diabetes, hypothermia, fetal distress, asphyxia, male sex, white race, being the second born of twins, and delivery by cesarean section without labor. IRDS may develop immediately in the delivery room in extremely immature infants at 26 to 30 weeks of gestation. Some more mature infants at 34 weeks gestation may not show signs of IRDS until 3 to 4 hours after birth, correlating with the initial release of stored surfactant at the onset of breathing, accompanied by the ongoing inability to replace the surfactant owing to inadequate stores. Manifestations of IRDS include cyanosis, tachypnea, nasal flaring, intercostal and sternal retractions, and grunting. Grunting is caused by closure of the glottis during expiration, the effect of which is to maintain lung volume and gas exchange during exhalation. Atelectasis is well documented by radiographic examination of the chest, which shows a ground glass haze in the lung surrounding air-filled bronchi. Severe RDS may show an airless lung field, whiteout, on a radiograph, even obliterating the distinction between the atelectatic lungs and the heart. These X-rays show a case of RDS. Picture A shows that the infant is intubated, and the lungs show a dense reticulonodular pattern with air bronchograms. Whereas in Picture B, surfactant was administered, resulting in significant improvement in the density of the lung. During the first 72 hours, infants with untreated RDS have increasing distress and hypoxemia. In infants with severe RDS, the development of edema, apnea, and respiratory failure necessitates assisted ventilation. Thereafter, uncomplicated cases show a spontaneous improvement that often is heralded by diuresis and a marked resolution of edema. Complications include the development of a pneumothorax, a patent ductus arteriosus, and bronchopulmonary dysplasia. For prevention and treatment of RDS, strategies to prevent preterm birth include maternal cervical cerclage, bed rest, treatment of infections, and administration of tocolytic medications. In addition, prevention of neonatal cold stress, birth asphyxia, and hypovolemia reduces the risk of RDS. If premature delivery is unavoidable, the antenatal administration of corticosteroids to the mother stimulates fetal lung production of surfactant. This approach requires multiple doses for at least 48 hours. After birth, RDS may be prevented, or its severity reduced, by intratracheal administration of exogenous surfactant immediately after birth in the delivery room, or within a few hours of birth. Exogenous surfactant can be administered repeatedly during the course of RDS in patients receiving endotracheal intubation, mechanical ventilation, and oxygen therapy. Early application of nasal CPAP may also reduce the severity of RDS. Because of the difficulty in distinguishing sepsis and pneumonia from RDS, broad-spectrum parenteral antibiotics, such as ampicillin and gentamicin, are administered for 48 to 72 hours, pending the recovery of an organism from a previously obtained blood culture. That's all for this video. Thank you.